Good afternoon, everybody, and from around the world, good morning and good evening. Thank you for joining us for another Science from Your Sofa special webinar. I'm Amy Lietman. I'll be your host today. I'm very pleased to have with us our two very special guest speakers, whom I'll introduce in just a moment. We're pleased to have you with us today. There we go. Today's topic is novel approaches for the discovery of treatment monitoring biomarkers in NTM lung disease. Our two guest speakers are Dr. Valentina Guierrini and Dr. Ross Klingsberg. Dr. Valentina Guierrini has a broad background in clinical and basic microbiology with training in prokaryotic molecular biology, genetics, and infectious diseases. For more than a decade, her research has focused on Mycobacterium tuberculosis, and she has published numerous scholarly articles on the subject. These include the testing of new anti-tubercular compounds against drug-resistant TB strains, and the identification of novel molecular targets for therapeutic interventions against TB. Dr. Guierini's current research focuses on macrophages, in particular foam cells, which are lipid-laden macrophages that are found in many chronic inflammatory disorders of humans and have impaired immune function. In the last 2 years, Dr. Guierini's interests have expanded to include non-tuberculous mycobacteria. She is the principal investigator or co-investigator of several studies, including the one she and Dr. Klingsberg will be presenting on today, exploring innovative research approaches to discover biomarkers of treatment response. Dr. Guierrini holds a Bachelor of Science in Biology, 2 Masters of Science degrees in Health Biology and Microbiology and Virology, and a PhD in Medical Biotechnology, which includes microbial biotechnology, vaccines, and infectious diseases, from the University of Siena in Italy. Dr. Ross Klingsberg trained at Tulane School of Medicine, where he completed residency and fellowship in internal medicine, pulmonary diseases, and critical care medicine. He also completed an internship at the University of Pennsylvania. He is board certified in all 3 of those fields and remains on the faculty at Tulane School of Medicine. His first exposure to non-tuberculous mycobacterial diseases of the lung were under the mentorship of the late Dr. Dean B. Ellithorpe, and he is currently the director of Tulane's Adult Cystic Fibrosis Program. He treats both CF and non-CF bronchiectasis, and also works in the Louisiana Department of Health Wetmore TB Clinic, as well as the New Orleans VA Medical Center. He is the principal investigator or co-investigator in several studies, including the one at heart of today's talk, which he and Dr. Guierrini are leading. NTM Info is very proud to be funding this project, and we're excited to learn more about it today. So for today, if you have a question, you can drop it into the question and answer box right there. You just type in your question, hit send, and it'll show up in the Q&A. At the end of the presentation, I will read the questions out for our presenters to answer. Don't forget about our upcoming presentations, Sunday, November 7th on NTM Nutrition and Body Image, Sunday, November 14th, Managing Effective Changes with Goal Setting, and another special Science from Your Sofa presentation on Monday, November 29th. Waterborne pathogens, microbiology, and mycobacteria, a very favorite topic of ours, with Dr. Joe Falkenham and Dr. Ted Maris. So look for those registrations to open shortly. We'd like to thank INSMED for the support of our programming this year. Without their support and the support of people like you, we could not do all the things we do for you. It's a pleasure to be able to bring all this programming to you this year. Don't forget to follow us on social media, and you can learn more and sign up for our latest news at ntminfo.org. Dr. Guierrini, Dr. Klingsberg, welcome. Thank you so much for taking the time to be with us today. The floor is yours.
Thank you, Amy, for the very warm introduction. I'm going to share my screen now. Okay. Hi, everybody. I'm Valentina Guierrini. I'm a junior investigator at the Public Health Research Institute. This is the institute you can see on the top left of your screen. The institute is part of New Jersey Medical School, and we are in Newark, New Jersey. And this study has been really a collaborative effort with Tulane University and with Dr. Klingsberg. So the topic for today is really to talk about novel approaches that we can use for the discovery of new biomarkers of treatment response in NTM lung disease. And since this is a collaborative effort, Dr. Klingsberg and I will alternate for this presentation. I would like to start off with an introduction of NTM lung disease. And actually, Ross, you have the floor.
Thanks, Valentina. So it's great to be here, and it's been such an honor to work with the foundation and with Dr. Guierrini on this project. I'm primarily a clinician, but I have great interest in advancing the science of the treatment of this disease because so many patients come to me with it, both with cystic fibrosis and without. So let me dive right in. This non-tuberculous mycobacterial lung disease sets itself apart from the grandfather of all mycobacterial diseases, tuberculosis, for which we have good treatments. In fact, the treatments are more well characterized and sometimes even shorter in duration than the ones we have for the non-tuberculous mycobacteria. It's a chronic debilitating disease. I don't need to explain that to this audience. And the treatment is fraught with challenges, including side effects, cost, uncertainties about the diagnosis. And often the patients who get these infections on sputum culture have other lung conditions that make it even more complicated because those conditions may have symptoms of their own that need to be differentiated. So I've alluded to this genus Mycobacterium, of which there are many subtypes. The distinguishing feature of these non-tuberculous infections is they're found in the environment, whereas tuberculosis seems to be a person-to-person transmission. These can come from the environment, and we'll talk a little bit more about that in detail in terms of the characteristics of the organisms and the environments that they live in. I won't go into all the species because most of the disease is caused by Mycobacterium avium and Mycobacterium abscessus, and broadly they're categorized as rapid growers like Mycobacterium abscessus, and that's how long it takes to grow in the lab, versus slow growers, which can take weeks to get a positive result. And I'll point out now and come back to it, this delay in getting an answer is part of the challenge. You get a patient with symptoms, you get a culture, and then you don't know what it is for weeks at a time while you're trying to make important treatment decisions. And just for context, tuberculosis would be a slow grower if you put it in this categorization. The prevalence seems to be varying around the globe and in different regions, but it's increasing. And these diagrams of the United States show, going from left to right, the change from 2008 to 2015. And if you study epidemiology, there's important words. There's the incidence of a disease. Those are the new cases. And then there's the prevalence. And with a condition like this that can last years and even entire lives, you can see that the darker blue color indicates a higher incidence or prevalence. The upper A2 maps showing incidence and the lower two showing prevalence. And you can see it's sort of almost randomly distributed. I think the bottom right is the bluest of the four diagrams, being the most up to date, and that's the number of people afflicted with this condition. You can see Louisiana is in there. Florida and Georgia have heavy prevalence as well. So this diagram has a lot of small words on it, and there's three groups. The box on the top is orange, and it shows the presence of the conditions that can lead to this infection, and they're listed. I'll read them: cystic fibrosis, alpha-1 antitrypsin deficiency, ciliary dyskinesia, pulmonary alveolar proteinosis. These are rare genetic conditions, but there are a lot of rare genetic conditions. Acquired conditions such as bronchiectasis, COPD, which is common, chronic aspiration, which gets more common with age, and neurological impairment, and even cancer. So patients with any sort of architectural or distorting lesion in the lungs are a setup for these organisms to grow. The historic term that is still out there is Lady Windermere syndrome, which is sort of an observation. We don't know why it exists. It may have to do with the chest wall anatomy, or maybe a certain alteration in the cough mechanism. And then there's patients who are on therapies to treat other conditions like autoimmune conditions. To turn down that inflammatory response, you turn off a part of the immune system that's causing damage. That can give the mycobacteria the upper hand to tip the balance and start to damage lung tissue and cause symptoms. So those are the host factors that a patient may bring to the situation. I'll go more quickly over the environmental and organism characteristics. These organisms live in the environment, and that's a big distinction between tuberculosis. And the warmer and moister the environment, the more likely the organism is to grow. One of the things that we're studying in collaboration with the School of Public Health is looking at the municipal water in our own region to see which areas of Louisiana have mycobacteria actually in the water supply. I don't have any early data on that, but we're studying it. And lastly, the prevalence and incidence are increasing, partly because of a greater number of patients with chronic conditions, and also better abilities to diagnose or grow this organism in the laboratory. It's actually quite difficult to grow. And if you don't have a specialized lab that knows how to tease it out of everything that's found in the sputum, you may not make the diagnosis. So with improvements in our ability to detect this sturdy and difficult to eradicate organism, we're getting more evidence that people have it. So those three factors, the patient, the organism's ability to survive in the environment, and the laboratory ability to detect it, have all come together to create this increasing problem. Next slide. Dr. Guierrini, I'm going to pass it to you.
Okay. So let's talk about NTM pulmonary disease pathogenesis. So NTMs are environmental bacteria. So you can find them in water sources. You can find them in the soil. And they tend to grow as biofilm. Biofilms are communities of microorganisms that kind of tend to stick together and then adhere to surfaces. And once they do that, they are very resistant to environmental factors, disinfectants, and they're very hard to eradicate. And they can grow as biofilms or as free living organisms in different type of water sources. For example, you can find them in natural water, like lakes, rivers, streams. You can find them in municipal water. You can find them in your tap, in your shower head, and this is how you get exposed to it. You can also find them in the soil. So if you do gardening, you can get exposed to the aerosol while you do gardening. And you can find them even living inside these microorganisms that are called amoebae. And these organisms can be found in the water or in soil. And there's been seen that some species of NTMs can actually survive and replicate inside these organisms. And sometimes, and also in some lab experiments have been seen that if the bacteria grow inside this organism, then they can actually change and even become more adapted to intracellular environment and more virulent. And then you can come in contact with the bacteria that are, for example, in the dust of your homes, and fomites that are non-living objects that are carriers of infectious diseases. So for example, this could be any object you can come in contact to in the environment, and in a hospital setting, for example, it can be a medical device. And even though for a long time it was thought that these infections, they could be, you can get these infections only from the environment, lately there have been many studies showing evidences that there is actually a person-to-person transmission happening. And this has been shown for Mycobacterium abscessus, and in particular in cystic fibrosis patients in hospital settings. So, and as Dr. Klingsberg said, there are a series of host factors that predispose to the infection. So you can have genetic disorders, like for example, cystic fibrosis, or underlying lung diseases, such as COPD or asthma, or for example, lung structural abnormalities, such bronchiectasis. And then if you have an infection in your lungs caused by another pathogen, then you are more predisposed to get an NTM infection. And then there are speculations that some lifestyle choices may be associated with higher chances of getting an infection, such, for example, smoking. Once the bacteria land in your lungs, then what happens is that your immune system reacts to it. And the first line of defense of the immune system is represented by innate immune cells. These cells can be, there are different types of immune cells, such as the ones shown here, like neutrophils, dendritic cells, macrophages. All these cells are trying to eradicate the bacteria. And for some NTM species and in some conditions, they are actually very effective, and the patient can actually clear this bacteria on their own. But for most NTM pathogenic species, and for some host conditions like the factors we have talked about, then the infection takes place, because these bacteria are able to have so many mechanisms to evade our immune system and can actually survive inside the cells of our immune system and replicate. And once when they are surviving in our immune cells, then stimulate the immune cells to produce a lot of molecules, and all these molecules are going to recruit other immune cells to the site of infection, and then you have the formation of this structure that is called granuloma, which is basically an aggregate of immune cells. And then our adaptive immune response takes place. So you have all these what we call lymphocytes that are coming to the site of infection and trying to contain the infection. And in some cases, and for unknown biological triggers so far, and this has been delineated for Mycobacterium abscessus, what happens is that the bacteria change their morphology and can actually induce cell death. So the cells release the bacteria, and the bacteria can start replicating and generate these big cords that are impossible for the cells of our immune system to fight. So when this happens, then your disease progresses, and then you have chronic inflammation and a lot of lung tissue damage. So really, what we want to address today and we want to talk about today is a big issue in clinical practice, that is, how do we monitor treatment response? And Ross, you can talk about this.
So, and this is the beauty of this. And I just listening to Dr. Guierrini talk, I get excited about the prospects of it, because it's difficult clinically to figure out if the patient should be treated or not. And it's difficult to figure out if the treatment is working. Why is that? Well, if I just go by how the patient feels, I'm certainly not getting any information about what they're culturing. If I go by their lung function doesn't always correlate with a clearance of the infection or a sense of well-being. And then if you get the culture and you want to go by, did the organism get eradicated? As I alluded to earlier, it takes weeks and weeks and weeks to get the culture. So perhaps there are markers in the sputum, in the blood, in the urine that can tell us what the body is doing. And these bullet points sort of address these issues. I'm not going to read them out loud for you, but that's basically there must be a better way to figure out, is the treatment working, is the treatment indicated, and how long to treat, which is another issue. So this slide I'll talk about too. So back in 2015, and time is sure flying as I get older, I'll admit, but a group of people got together to identify some priorities, and they got together in Portland, and there was, I think, 24 people there, patients, patient advocates, scientists, clinicians, and the priority was identified to look for biomarkers associated with disease risk, prognosis, and the treatment response. I can tell you, I do this already. The biomarkers that we have are too blunt. It's like fever present or not. Well, fever is kind of like check engine light. Boy, don't you hate that when the check engine light comes on? Like, what do you do now? Like, what do I check? There's so many things. Fever is non-specific. You could go by the white blood cell count. That's a little bit better, but still, it correlates poorly with the activity of disease. I look at something called high sensitivity C-reactive protein, which looks at inflammation throughout the body in the blood vessel walls, but again, very non-specific. And it's sort of a surrogate, a biomarker, but we need something more precise, and patients need something more precise. So that's kind of why we're doing this.
Okay.
I'm going to pass it back to you, Dr. Guierrini.
Okay, so this is a way to give a definition of a biomarker. So what is a biomarker? And this is the definition that is being given by the Institute of Medicine. So a biomarker is something that you can measure and that you can evaluate as an indicator of normal or pathogenic process, or an indicator of a response to a therapeutic intervention. So, for example, to the treatment. And the biomarker is something that has to be measured over time in order to assess presence, extent of disease, and to provide evidence of an intervention effect or exposure. For example, exposure to a medical product like a drug. So when we want to interpret a biomarker, we don't want to interpret the biomarker on a snapshot level, but we really want to interpret the biomarker based on the changes that this marker has over time. So we want to do serial measurements. For example, you want to take your samples, that can be a sputum, can be urine, can be blood, and we want to measure something over time. And is that change that then tells us if you are responding to the treatment. And why is a biomarker so important? First of all, we have said a biomarker is important because it can guide the clinicians in their decisions. So if they need, for example, to intensify or de-escalate your therapies. But also a biomarker is important in the context of drug development efforts, and actually having something that you can measure during the clinical trials is very important for drug development. So most part of the research that has been done so far really has focused on trying and find biomarkers by looking at immune responses and by using blood-based assays. And most of these studies have just picked the targets that they wanted to measure. For example, there are studies about measurement of antibodies that are specific for NTMs, or measure specific mediators of inflammation, like cytokines, and other markers, like, for example, this carbohydrate antigen that has been used also for cancer. So very few studies, only blood-based, with selected markers. And sometimes these results have been also controversial. So we really need to find a new way of finding biomarkers. And that's the reason why we decided to start this partnership. And our collaboration really started a couple of years ago, and we were put in contact by a common colleague, Dr. Chris Vinnart, that now works in Sanofi. And really, this collaboration is the perfect example of doing translational science. So Dr. Klingsberg, he directs the pulmonary clinic at Tulane, is the one in New Orleans, in Louisiana, is the one really interacting with the patients. And I'm in Newark, New Jersey, and I'm really a bench scientist, so I'm more expert in the experimental part of the study. So I'm the one analyzing these samples. And then what we're trying to do is to try and work together to find something that then can be really used back by Dr. Klingsberg in clinical practice to better the management of this disease. So this is really the example of translational science, going, what we say, going from bed to bench and then back to bed again. And I wanna, yeah.
Well, I wanted to jump in here. You know, we looked at that incidence and prevalence slide before, but this map of the United States, red indicates the incidence of NTM disease in patients with COPD using a large VA database, and you can see that I'm really in the hot zone, right in the center of that red circle. It doesn't correlate as well with the overall incidence that you saw in the earlier slides, where some of the Northwestern states had a higher number. I'm not sure if that's due to migration of people or what, but you can really see Florida and Louisiana and southern Southwest on the coast have it. So that was just, I think this is a beautiful slide to indicate the burden of disease in certain regions.
So I want to introduce you to the team of the study. So Carol, she's the clinical research coordinator at Tulane, and she has been the one enrolling the patients. And then Jana, she's a medical research specialist, and she's the one processing the samples in the lab. And then Amy and Tamika, they are residents at Tulane, and they have really helped us in the collection of the clinical information from these patients. So what is our novel approach to biomarker discovery? So what's new, what's novel about that, what's different? So our approach is focused on the lung microenvironment. Previous studies that I've shown you before, they were looked really at blood. So what happens in blood may be especially our immune system, may be not exactly the same as what happens in the lungs, where actually the infection takes place. So we want to focus on the anatomical site where the infection takes place. And this is a very complex environment. So it's an environment where you have multiple players. You have the bacteria, you have the host cells, different types of cells of our immune system, and there is a continuous interaction between these elements. So we want to look and take really a picture of this environment. And we want to do this in a way that is unbiased. So we don't want to select the markers we want to look at, but look at the whole thing, comprehensive. So all the components of these microenvironments, we want to analyze everything. And we can do that using what we call the high throughput strategy. And this means that we really want to measure as many as possible markers we can. So we want to really measure thousands and thousands of markers at the same time. And this is just a cartoon showing you all the players that you can find in the lung microenvironment. So you have the pathogen, that's the bad guy. You have the normal bacteria that populate our airways. And then you have many different types of cells that are cells of our immune system. And then you have cells that are part of your respiratory tract, so that are present in your airways. And all these components, all these elements, they interact directly or indirectly, and then they affect each other behavior. So our study has been divided in two aims. One aim that is mostly focused on looking at the host side of the lung microenvironment. So all the host cells, the immune cells, and the cells of your airways. And then aim two that is focused on looking at the bacterial side of this microenvironment. And we use, in order to describe these two components of the lung microenvironment, we use these technologies that allow us to measure many, many markers at the same time. And one of them is proteomics. This is a technology that allows us to measure all the proteins that are present, for example, in a clinical sample, like blood or sputum. Transcriptomics that allow us to look at the expression of all the genes of our genome in those cells. And then metagenomics, that is like the whole genome sequencing of all the bacteria that are present in our airway. And then these findings can be correlated with the clinical status of the patients. And then with these correlations, we can identify what we call host correlates of treatment response, so markers of treatment response that are host molecules, and markers of treatment response that are microbial components. And so what do we expect to see when a patient is responding to the treatment? So what changes do we expect to see in the lung microenvironment when there is treatment response? So when we have disease in the lung, then you have all the bacteria that are causing the infection, the cells of your immune system that are trying to fight the infection, and they produce a lot of inflammatory molecules. And then you have also a lot of cells that are dying because of the infection and contribute to this inflammation. You have biofilms of bacteria accumulating in your airways. So then you have like this chronic inflammation happening And the chronic inflammation then causes a lot of tissue damage. And this type of environment has been associated with a change that is called dysbiosis, a change in the type of bacteria that are present in your lungs and contribute to the pathogenesis. So if you are taking an antibiotic treatment, and if you are responding to the treatment and you are clearing the infection, what happens is that you are going toward a healthy lung again. So what happens is the inflammation goes down, the tissue starts healing, and you go back to a normal type of flora, microbial flora in your airways. So you go back to having a normal amount and normal types of bacteria in your airways. So this is what we are trying to monitor over time and to see if you are really responding to the treatment.
Valentina, I wanted to point something out there on that last slide for the audience. So this image represents one air sac, one tiny alveolus in the lung, of which there are millions. And this is the place where gas exchange occurs. So oxygen has to get from the air, where it says healthy lung, into the blood, which is, it has to cross through those cells to get oxygen into your body. And then carbon dioxide has to be released into that space. So for gas exchange to occur, when there's all of these extra cells fighting an infection, reproducing in your lungs, gas exchange can be impaired. And that's really the disease process. But I really wanted to emphasize this is one alveolus in the lung. That's it.
And then, so how can we monitor these changes in the lung microenvironment? And the way we do that is by analyzing respiratory samples. So we can collect induced sputum, and you're probably familiar with the process. The patient inhale saline, a saline solution, to induce the patient to expectorate, and then the bronchoalveolar lavage. When you actually are washing your airways and taking this liquid out, and then you analyze this liquid. And it's been published by many studies that these types of samples are actually representative of the lung microenvironment, so of the lower airway microenvironment. So what do we expect to find in these samples? We expect to find all the components of the environment I've shown you before. So we expect to find immune cells, we expect to find bacterial cells, and we expect to find all the molecules that are produced by these cells. Those could be molecules regulating inflammation, regulating immune responses, or that they can also be released by the death of when these cells die. So we have designed a longitudinal cohort study. And in this study, we enrolled patients with NTM lung disease. And we have 3 visits, 6 months apart. And for the patients who will be undergoing treatment, we collect samples at visit 1 before they start antibiotic treatment. So for each one of these visits, we collect different type of specimens. So we collect 2 sputum samples, because 1 sputum will be used to study the host molecules, and 1 sputum will be used to study the bacterial component of the environment. And then we collect oral washes to see also what bacteria are there and how they compare with the bacteria that you have in your lower airways. And then we collect blood and we collect urine. And during the study visits, we also collect all the clinical information, so results of microbiology, pulmonary function, CT scan or X-ray results. And we give, at each visit, we give the patient a questionnaire, and the patient, that is the St. George questionnaire, answers questions about the symptoms and the quality of life.
So as you can imagine, gathering all that data gets rather complex to sort it all out and create a definition of a signal in these host and microbial factors. So we had to define who was a responder and who was not. So the primary outcome was, did the culture clear? We monitor the sputum about once a month, or as often as we can get it. And let me tell you, it was hard to get sputum during the COVID pandemic because people weren't exactly excited about coming into the hospital and coughing all over the place and collecting sputum. But we did collect sputum and monitor it for conversion, and as defined by the NTM guidelines. We did follow those secondary outcomes that are so crucial to patients, such as, do patients feel better or not? Did their X-ray stay the same or even get better? What we don't want to see is it obviously getting worse and halt the progression of disease. And lastly, we look at pulmonary function, which isn't a really precise way of monitoring the presence of or absence of NTM disease. And then with those outcomes defined, we correlate with the bench work that Valentina does in the clinical samples that we send up. Next slide. So it was difficult to get everything in place and get as many patients as we hoped, but we are picking up momentum as time goes by. In the first year, we had 13 patients enrolled, and I'll show you a summary slide in a moment. One of them had severe disease pre-existing and passed away, and then we got follow-ups, and so this is the summary slide. You can see that the patients are de-identified and given a number. And in the first cohort that we're presenting here, they all had MAC pulmonary disease, mycobacterium avium complex. And you can see the comorbid conditions. We cast a broad net. We weren't selective. We wanted to get all comers and really get as much information as we could. So we have idiopathic bronchiectasis, some acid reflux disease. CVID stands for common variable immune deficiency. That's a deficiency of antibody production into the airways as well as other systems. We had a patient with farmer's lung or extrinsic allergic alveolitis, bread and butter, COPD, emphysema, lung cancer. One patient was only diagnosed with melanoma, didn't have a cause for the NTM disease other than the risk factor of treatment for melanoma. And then you can see the average FEV1 ranged anywhere from 22 was the lowest to one patient, patient 206. He had very good lung function, but he was plagued with chronic coughing that disturbed him every night. The next, third to the last column from the right shows if the patient was treated or not. And I probably don't need to explain to this audience that treatment is not easy. Sometimes the treatment is started and there's an interaction and it's not well tolerated. And so we had patients on partial treatment. We had patients who started and then stopped. Some patients had reactions to other medical problems that made them stop the antibiotics to figure out what was going on, and then they started them again. Now, the second to the last column shows did the organism clear. We had clearance in 2 out of the 8, and 3, I'm sorry, and persistence in 4. Some of the patients clear the organism on their own. So we enrolled them, we got culture on the first visit, and then they started antibiotics and the culture cleared. And as you know from the treatment guidelines, you continue the antibiotics even after the organism is cleared to prevent it from reoccurring. And of course, who doesn't care about quality of life? Patients want to feel better. So we we defined our quality of life as improved as a happy face, and no change, no improvement, or worsened is a sad face. And I think it's easy to see here that this still remains a significant challenge, because most of the patients that we're following have not cleared it or still have symptoms. So we're picking up momentum. What's happened with increased clinic volumes is we're starting to get a rapid uptick in patients that we're enrolling, and this last batch, we're sort of filling in the CF arm of the study to look for differences in that response. I'll share sort of an observation. This is not for publication or anything, but even in a condition like COVID, we see a different response to the virus in the CF population than we do in the non-CF population. And that may be true among the non-tuberculous mycobacterial diseases, but we want to see what those differences are. So we included CF patients with non-CF patients, which a lot of studies, if you read the literature, are looking at one group or the other. So this study is ongoing, and enrollment is increasing. I'm going to pass it back to you, Dr. Guierrini.
So today I want to show you some preliminary data that we got for aim 1 of the study. So looking at the host component of the lung microenvironment by using these high throughput technologies. So I want to start off really explaining you how we process the sample when we get it. So we get either sputum or bronchoalveolar lavage. And the first thing that we do, since this sample is very sticky, we add one agent to liquefy the sample. And then we try to separate two parts of the samples by doing a centrifugation. And we want to separate whatever is soluble, like soluble molecules, from particulates, like cells. So in the top part of the sample, you have soluble molecules, like, for example, mediators of inflammation, regulators of immunoresponses, and some molecules that can also cause tissue damage. And we store these sample in our freezers. And then for later analysis, at the bottom part of the tube, we have the particulate matter. So we have the immune cells. And these immune cells, what do we do with these? Part of the cells, we analyze and we check by using our microscope to see if the sample was a sample of good quality, because sometimes the patients have difficulty in expectorating, and we find samples that are highly contaminated with saliva. So we have to consider that samples are unsatisfactory and they cannot be used for the study. And then we also do a cytology analysis. That is an analysis where you can look at the different proportions of the immune cells in the sample. And part of the cells we freeze for a later analysis. So what is proteomics and why we decided to go for it? So proteomics is the analysis of the whole proteome. This means all the proteins that are present in the sample. And why we go for proteomics? First of all, we said we wanted to do an unbiased analysis. And this is, so we don't select any targets beforehand. We look at all the proteins. This is high throughput, so allow us to really measure thousands of molecules at the same time. And we can get a relative quantification of all these proteins that are identified. And proteomics has been used by several previous studies to analyze sputum samples from healthy subjects or from subjects with tuberculosis, COPD, asthma, and others. And has been used also to try and find biomarkers of disease progression, and treatment response. So we decided to use it also for these cohorts of patients. And so I'm just gonna try and explain these in a very simple words, because all the proteomics is very complicated even for me. So in order to be able to analyze proteins, the first step is to isolate those proteins from the samples. Once the proteins have been isolated, then we cut them in smaller pieces, and these smaller pieces are called the peptides. And then these smaller pieces are labeled with special reagents that allow them to be detectable by an instrument that is called mass spectrometer. And once your sample is loaded in this instrument, then you can detect all the proteins that are present in that sample, and then you do data analysis, and you can quantify those proteins, and you can do even more sophisticated analysis and compare the protein profiles between different samples. So far we have applied proteomics on sputum samples collected from 6 patients, because those are the patients that completed both visit 1 and visit 2. So we could compare the 2 visits. And these are the clinical lab results from the sputum cultures for these patients. So we had one patient that did the full treatment during the 6 months and converted. Then we have 2 patients that converted, but in reality, they started showing their first negative culture just right before starting treatment. So we are not sure if this conversion really started happening right before starting treatment, and we don't actually, unfortunately, have the sample of when the patients were fully positive for this time point. And then we have 3 patients that didn't do the full course of treatment because they had to stop due to side effects, and they didn't convert, and they remained positive till month 6. These are the results of the proteomics from these first 6 patients. So this is just a way of visualizing the data. This is a heat map that is a graphical representation of the data, and is color coded. So the least abundant proteins are in blue, and the most abundant proteins are in red. And each line of this map is a protein. So we are here measuring thousands of proteins. And on the x-axis, you have the sample. So each column is a sample. And you have the patient number and the visit number here. And this is really a way of looking at the profiles all together from all the samples and see if you can try them visually to find similarities. And we can ask the software to do a more sophisticated analysis that is called hierarchical clustering. So this is a completely unsupervised. So we don't say to the software the identity of the samples, and the software is going to try and group the samples based on their similarity. So these 3 here, this is the dendrogram at the top of the map, and this is the output of this analysis. And as you can see, the software grouped the samples based on similarities and created 6, what we call 6 groups or 6 clusters. And actually, if you look at the number of patients, you can see that each patient cluster, so the 2 samples from the same patient cluster together. So you have 1 cluster per patient. So this means that each patient has a very unique proteomic profile that is different from the other patients. And then if you try and make more groups and ask the software to also compare between the groups, you start finding also similarities between the groups. And then you see, even visually, you can see that these 4 patients are more similar to each other than the number 203 or the number 201. And then if you ask the computer again to make a new comparison at a higher level, you also see again that, for example, the 203 is very different from the rest of the group. And actually, this is the only patient for which we have analyzed bronchoalveolar lavage. Instead, for these other patients, we have analyzed induced sputum. So partly the reason why this looks different, it could be the type of sample. Then you can even do a different type of analysis that is called principal component analysis. And what this analysis does, this analysis try and transform the data from high dimensional space to a few dimensions. So what does it mean? Basically, the software takes thousands of features that are all the proteins that we have measured in one sample and try and put those data into 2 axes. So here, for example, for this sample, for this patient, all the proteins are condensed in one spot. So it's like all the proteins are all together in this spot. And this is very useful to try and find patterns and trends, because now the proteins are just in one point. And if you look at this graph, you can see that most of the samples, they try to be in this area of the graph. And these are exactly the same patients that we have seen the heat map before, that were more similar, the 4 patients that were more similar to each other. And then you have these 2 patients here that we have seen before, the one from whom we have collected the bronchoalveolar lavage, and this patient here that is actually the only converter that we have that are completely different from the rest of the group. So now, what does this mean? This means that the patients, of course, they have sputum proteomic profiles that are very different from each other, first of all. Then you can see that most of the patients that try, they are located in the same spot of the graph, so they're more similar to each other. Then they are to these other 2 patients here that completely stand out. Now, this is very useful when we want to correlate these with clinical features. So we don't have enough samples or patients yet in order to do that. But once we have enough samples, then we can see if these clusters correlate with specific clinical features of the patients. For example, if all the converters are in one cluster and all the non-converters are in a different cluster, or if some of these spots, they tend to distribute based, for example, on a pulmonary function or symptoms or any other outcome measure. Even though all the patients are very different between each other, you can still try and find if they have something in common. If patients with similar outcome have something in common. So far, we have just the non-converted group with at least 3 patients. So we have analyzed only this group for now. And what we're trying to do here is to try and see if these patients that didn't convert because they didn't do the full course of therapy, if they have something in common in their sputum that changed from visit 1 to visit 2. So something that changed commonly over time. And the way to do that is to do this type of analysis. This is a volcano plot. And each protein here is one dot. And you can see the names of some of the proteins. And on the x-axis, you have the ratio between visit 2 and visit 1. So it's basically a comparison between the two visits. And then on the y-axis, you have the statistical significance. So if a protein increase the expression over time from visit 1 to visit 2 will be on this side, on the right side. And if a protein decreased its expression from visit 1 to visit 2 will be on the left side. And only the one above this horizontal dotted line are the ones that are significant. So if you look at this plot, you can see there are a few proteins here that are significant in our analysis. And there is a few proteins that are increasing, especially this one, over time. And there are some proteins that are decreasing over time. And these are 14 proteins. And then you can actually look at the heat map of only these proteins. So now the proteins are here on the y-axis. Each line is one protein. And again, the color reflects, is proportional to the abundance of the protein. So if it's low abundant, is blue. If it's high abundant, is red. And you see here the patient number and the visit number. And then again, you can start making clusters. So you can start seeing if some of these patients are more similar to each other, and you can make clusters of samples. So you can see that the patient 204 and 206 for visit 1 are similar to each other. Same goes for the 204 and 206 at visit 2. And then what is really striking is that you can see that there are these two big groups, and these two big groups are, one includes all the samples from these patients of visit 1 that tend to be very similar to each other, and another cluster includes all the samples from visit 2 from the same patients that tend to be more similar to each other. And then you can ask the software even to look at proteins that have similar trends in these patients. And you can see that there are like two main clusters. One cluster with three proteins, these three proteins that go from blue to red. So from low abundance to high abundance, from visit 1 to visit 2. And then these 11 proteins here, they share a common trend going from high abundance to low abundance, from visit 1 to visit 2. Now, why is this meaningful? Because at this point, you can look at the functions of these proteins that we have seen so far, and you can see if these proteins are, for example, important for inflammation or immune responses, or what other molecular pathway. And in this case, we find that many of the proteins that whose expression changes in common in these non-converted patients are proteins that are involved in inflammation, immune responses, antimicrobial activities. So I'm not going to read the function of all the proteins that we have identified, but I've just highlighted what's important for their function. And you can see that most of the proteins that we have identified, we see words like immunosuppressive, immunomodulatory, inflammation, recruitment of immune cells, antimicrobial activity, inflammatory mediators, monocyte migration, immune responses, lymphocyte function. So many of them are actually involved in inflammation and immune responses. So this means that being persistently infected with NTMs is associated with a change over time in the abundance of molecules that are immunomodulatory in our respiratory tract. So I want to end this summarizing what we have talked about today. So we have tried to adopt a different way of discovering biomarkers of treatment response, looking at the lung microenvironment. And the way we look at the lung microenvironment is by analyzing samples that represent the lower airways, such as sputum or bronchoalveolar lavage, and monitoring them over time by using high throughput technologies that allow us to measure multiple targets at the same time. And then by correlating these findings with clinical features, with outcome measures, we can find and identify candidate biomarkers. So far in the study, we have enrolled 13 patients, and 2 of them have completed the first 2 visits. And for those 2 patients, we have applied proteomics on the sputum samples. We have seen that the proteomic profiles of the sputum change with the subject, but even if each subject has a specific proteomic profile, you can still find common changes over time in patients with similar outcome, such as patients persistently infected with NTMs. And we hope to apply the same approach to the group of the converters and find something that changes in common in the converter group. So we are enrolling more patients now, and we're going to do the proteomics on all the sputum samples. We will correlate that with the outcome measures. And then our plan is that once we have identified those targets, we will validate them by using a different technology. We have used mass spectrometry so far, so we want to use another technology to do that. For example, immunoassays, and look at this and use this technology on a different cohort of patients. And then if we find molecules that can also be found in blood that are known to be circulating molecules, then we can try and see if we can measure them in blood, because that would be very applicable to clinical practice, and we won't have to ask the patients to produce a sputum sample, but we can just do a blood draw. And then we will continue with our study to finish AIM-1, so to analyze also the cells of the sputum and to look at all the genes that are expressed by these cells. So we can analyze, for example, by doing this analysis, we can see what are the relative proportions of immune cells in those samples and their immune functions. And then for the AIM-2, we can do the whole genome sequencing of the bacteria in the sputum that allow us to see what's the relative proportion of the different bacteria in our respiratory tract and their functional characteristics. And then, since all these technologies are applied to the same samples, we can actually see if there are links and correlations between the 3 readouts. And I wanna finish saying that this study doesn't only allow us to find candidate biomarkers of treatment response, but finding markers that correlates with disease outcome can actually open new venues of research, because it can generate hypotheses, for example, on disease pathogenesis. So if we see that a marker is correlated with the sputum culture conversion and with treatment response, it's possible that that protein is important also for the pathogenesis, and then it can be a target for therapeutic intervention, for example. So it can stimulate additional research. And I want to acknowledge from Rutgers University, Peter Lobel and Haiyan Zhang from the Proteomics core facility, and Alex Lamenze is the computational biologist who did the analysis of the proteomics data. Chris Finnard, because he's really the father of this collaboration, this collaborative project. And Maria Laura Gennaro has been my mentor for many years, and I want to thank her for her support. And Tulane, all the people have participated in sample processing, Jan and Carol for the patient enrollment, and Tamik and Amy for the collection of the clinical information. And a special thank to NTM Info Research, because really it made this possible, and without this funding, we wouldn't have had the possibility to do the research we have done so far. And thank you for all the attention, and questions are really welcome.
Thank you. We do have a number of questions in the queue now, so we will get going to that. I will start reading those questions out. Let's start at the top. What is the mechanism behind CA19-9 biomarker for lung inflammation, and can you comment on its specificity and sensitivity to the NTM treatment outcome?
So this was a study, now I don't remember the authors of the study. I think they took the idea from cancer research, because this is a biomarker that is being used for cancer. I don't think I'm not sure if this marker relates to inflammation. I know that has been used to as a biomarker in cancer, but I'm not sure if it relates really to inflammation. And in the context of NTMs, in this study, they have tried to look at it and see if this biomarker correlated with sputum culture conversion, and I don't think they really mentioned the role of this molecule in the inflammation process. They just measured this marker because they took the idea from the cancer research.
Okay. Is it valid to assume that after infection, the microbiome recovers to a healthy system? It seems to me that it would be just as valid to hypothesize that a new microbiome community, somewhat diminished due to antibiotic therapy, would establish itself. Can you comment on that hypothesis?
I think it's possible. I think that definitely there are changes happening during the antibiotic treatment, and this actually has been studied and has been shown. So whenever you have, but in general, in our bodies, whenever you do an antibiotic treatment, you have changes in our microbiomes. That's why you take, for example, probiotics after taking antibiotics, because you want to reestablish a good microbiome. Going back to normal, normal is hard to define. I think normal, each patient has his level of normal and can be different from another patient. I think that if you clear the infection, it doesn't happen immediately, but at some point you will go back to a healthy microbiome. This doesn't mean that it's necessarily exactly the same as the microbiome you had before you got the infection. I think it's possible that some changes have happened, and I think it's possible that doesn't look exactly the same as before getting infected.
I can speak to this a little bit too from clinical experience. So in cystic fibrosis, we've had a revolution in the treatment of the underlying reason for having altered mucus in the airways. And what I've seen over time is patients who were persistently infected with Pseudomonas or an NTM may have cleared it with or without antibiotics. And then since the underlying defect has been corrected, the sputum culture reverts to normal flora, bacteria that aren't thought to cause disease. And the way they got back there is they were taken off antibiotics, which brings up the very good point, which I'm sure that is behind this question is, well, if I keep taking antibiotics for a year after the infection's cleared, maybe that's going to select for antibiotic resistant organisms. And that does bring up the need to know, when is it safe to stop the antibiotics against the mycobacteria, because they obviously will affect regular bacteria as well. And a healthy human physiology has a healthy microbial flora that you live commensally with or symbiotically with. And so that's a great question.
Yeah, I think it's a very good question. But again, going back to normal, it doesn't mean necessarily that's the same exactly, it's gonna look exactly the same as before you got infected or started treatment. I think it's very possible that when you do the treatment, and this has been shown in other contexts, that you have a selection of certain microorganisms because they have some drug resistance, right? So the microbial community will change, definitely, with the antibiotic treatment will change. Now, when you stop the antibiotic treatment, if that flora is gonna look exactly the same as before your disease and getting treatment, I don't know, but I'm sure that it's very possible that can look different. It doesn't mean that it's pathogenic, so it's normal flora, so it's not pathogenic, but it may be different from what you had before.
Okay. We do have a follow-on from one of the previous questions. Follow-on comment on CA19-9. I have been seeing a CA19-9 trend in time, plus 65% from baseline to NTM diagnosis and symptoms, and then a reduction of 80 to 85% just using hypertonic saline 3% nebulized. I don't know if Dr. Klingsberg, if you can comment on the use of hypertonic saline nebulized. I will say a little plug for our research funding. The other study that we have funded is the investigation of inhaled hypertonic saline as an adjunct therapy. So that's also in the works as well. But I don't know, Dr. Klingsberg, do you have any?
I can speak effusively about hypertonic saline. I'm less familiar and don't use CA19-9. In fact, I was sort of looking it up as we were talking here. It's historically taught and used as a cancer marker, but like I had used high sensitivity C-reactive protein as a marker of inflammation. That's really what we're after. Now the saline, when I was a fellow, that study was done in cystic fibrosis patients as a way of using the osmotic force, which is just the chemical force. You put a concentrated sodium chloride in the airway, and that will, like a sponge, draw moisture from the walls of the airway into the airway itself and facilitate the movement and clearance of anything that's there. Remember, we looked at that alveolus with all the inflammation and all that junk impairing gas exchange. Well, that was an alveoli, but that also occurs higher up in the airways. And I use hypertonic saline on virtually every bronchiectasis patient I have, especially if they say it's in there, but I can't get it out. And it is a little bit of work, and I try to counsel them. This is like going to the ocean. Who doesn't breathe better when they're at the ocean side and the surf and that sea salt air is there? So I try to put it in a positive light. It also has the appeal of being almost like a homeopathic therapy. There's virtually no side effect other than it can be a little bit irritating to the airways. Now, what we recommend is the 7%, which is hypertonic, more concentrated than the human body. If that's too hard to take, I will recommend cut it in half and use 3.5% or 3%. And that's about the salinity of seawater, which I think is very well tolerated for almost everybody. And you know, the salinity of our blood is about 0.9%. That's normal saline, or almost 1%. So hypertonic saline twice a day is absolutely recommended. And if you can't take it twice a day, once a day is okay. There's no tolerance to build up. It's very inexpensive. Even just retail off the shelf, it can be as low as $35 a month. And the only people who I don't have on it are the people who just don't like it and don't take it. I use it in virtually everybody to facilitate airway clearance. Vital. And on that note, everybody should be on a good diet. And I was excited to see the future talks, a physical therapy or physical exercise program, and even a mental health, spiritual approach to keep sleep and anxiety and these other things that can drive bad health outcomes as well. Great question.
Well, and as luck would have it, we do have nutrition and emotional well-being programs that we've been running this year and will continue into next year. So patients have long recognized the need for those things, and our patients are very keenly aware of the benefits of inhaled saline as an adjunct therapy. It's become very popular. So we're very glad that it's being studied as well in the non-CF population, hopefully to become something that can be really, you know, the benefit can be demonstrated.
It can be challenging when it won't get covered by insurance.
Which is why a clinical trial is going to be very helpful, we hope. Yeah. So another question on response to antibiotic treatment, does that mean it's a healthy lung? Does it repair the tissue, or does it just stop the damage? And can bronchiectasis ever be repaired?
I think this is a very great question. Yeah, I think this is a question for Dr. Klingsberg. So yes, in my presentation, I said healthy lung to make it simple, but probably I'm not sure if you're going back completely to normal, or maybe it depends on the extent of the disease, if you're really going back to normal or not.
I think that's absolutely right. You know, and that's why the lung function doesn't get better. Sometimes with CT scanning, we'll see airways that are plugged, opened up, and there will be a repairing process. Sometimes I'm amazed at how focal lesions in the lung, or what looks like an abscess, will completely resolve. But diffuse bronchiectasis doesn't go away, unfortunately. Once the airways have been damaged and scar tissue forms and they're dilated, they'll stay that way. And that's what creates the vicious cycle. That creates a little microenvironment that inhaled bacteria can take advantage of. So
for progressive disease, even so, if the disease is very severe, even if you're responding to the treatment, you don't really go back to, let's call, not really healthy lung, but you can still see changes in molecules involved in inflammation or tissue damage, because the tissue gets repaired and the inflammation goes down. So even though it's not completely healthy, you should still be able to see changes in those molecules. Then maybe for diseases that are less severe, and as Dr. Klingsberg said, they resolves, then maybe you can have a resemblance of a healthy lung.
And another thing that extends from that is if the airway is damaged and you can't restore it, there may be a role for prophylactic antibiotics to keep the balance in favor of the host and not give the upper hand to the opportunistic infection.
Crowd control.
Yeah.
Yeah. What is the significance of collecting a urine specimen?
Oh, okay. So in this case, the collection of urine was done to have that sample for a later time. So meaning once we have identified some targets we're interested in, then we want to be able to see if we can measure those targets in other samples, like I've mentioned, blood and urine, because that would be, would make things even in clinical practice much easier if you can just measure something in urine or blood. And this is for the purpose of the discovery of biomarkers. Then there is also parallel study that we are doing and trying to see if we can actually find some bacterial components in the urine, and this can be used as a biomarker of treatment response, or it can be used for diagnosis.
Okay.
There are other examples like Legionnaire's disease, where we'll get a urine sample, and that can, for certain subtypes of Legionnaire's, we can tell if the patient has it just by getting a urine sample, which is
helpful. If you're using a vest versus antibiotics, can you participate in your NTM study? So I guess if they're saying if they just are using airway clearance versus antibiotic treatment.
absolutely. I mean, we're looking at clearance, and we've enrolled people who, and this is the clinical dilemma: do I pursue a watchful waiting approach, or do I go down the path of treatment? Because it's a long commitment once you start treatment to stay on it. And I can tell you from experience, there are people who grow it a few times and then they clear it. And they didn't require treatment, but virtually all my patients are on vests. And a number of the cystic fibrosis patients in the second slide I presented are in the study submitting sputum, but we're just following them without antibiotics. So absolutely.
Okay. How can you confirm which patients are being constantly re-exposed to the pathogen versus patients that are clearing the existing infection? So in other words, maybe they're being exposed by water or soil that they're around, like, or maybe they're just not clearing the infection. Like is it maybe I guess they're asking, like, can you figure out if they're just being re-exposed to the same pathogen versus clearing and then reinfecting, or versus not clearing in general?
So in our case, we're really interested in seeing, in finding something in those samples that correlate with the sputum culture conversion. So we are not really looking at the reason why they are culture positive. We're just looking at ways of using something as a surrogate measure of sputum culture conversion.
Right.
But if you wanted to answer that specific question, you could do it, and you could do it by sequencing the isolate and then seeing if you have the same isolate in your water, and if the isolate is in the water and in your system.
Okay. All right. MAC is quickly going to be outnumbered by other patients with things like Xenopi, Kansassii, but studies seem to be geared towards MAC or intracellular patients. Are you looking at patients who have pathogens other than MAC or the Mavium complex?
Oh, absolutely. It's just that they didn't come around. So these are the patients that Dr. Klingsberg sees, but we don't have that exclusion criteria.
Okay.
Yeah, I'm not selecting people because they have MAC. I'm just taking any NTM. So that's sort of a random sample. We had one patient referred to the study from an allergist who was screening all of their patients for NTM, and she had Mycobacterium Kansassii. But once we got her in the clinic and we repeatedly checked her, she never grew Kansassii again. So this is just a reflection of what's out there. I didn't know that was the prediction that these other species of mycobacteria would outpace.
I don't know exactly what the epidemiology is going to show going forward. I know that MAC is the dominant strain here in the United States anyways. I know that Kansassii is also one of the more dominant strains, but I think MAC is probably the most dominant strain, at least right now. I guess we'll see what happens over time, but I think if I think they were just wondering if other patients with other species could get involved in these studies. And
Oh, yeah.
I think it's important.
Yes, the answer is
Great.
yes. We take all
Okay.
mycobacteria are welcome.
Okay, great, thanks. What precautions should be taken while collecting pulmonary samples?
So I think also Dr. Klingsberg can comment on that.
So,
But definitely we want to try and minimize saliva contamination. So usually the patient is asked to do a mouthwash. And then after that, the induction is started. So this is the only precaution I know but for the quality of the sample. Not on the patient side. I don't know if on the patient side, if you take any precaution.
as with many aspects of the treatment of these mycobacteria, we kind of get insights from tuberculosis. So we put patients in a chamber that has filtered air. So they go in there for the sputum induction. I wasn't sure if the question was directed at contaminating others in the environment or making sure that the specimen was accurate.
It wasn't really clear, so I guess you could answer both.
Yeah. So we take precautions, and in this era of COVID, we're all comfortable with masks and things and ventilation issues.
I don't know, maybe if the patient has asthma, then you administer something, right?
Yeah. We might pre-treat with albuterol before the hypertonic saline. That's the recommended sequence. I get a lot of patients who take the saline and then they take the albuterol afterwards. I think it's important to bronchodilate first. So if there is, first of all, to open the airways, and then second, to prevent a bronchospasm that might be induced just from the presence of a foreign substance in the airway that could trigger a reaction. So those are the main precautions, and I think this concern of transmitting mycobacteria from one person to another is a newer thing. It was taught historically that you don't get MAC from your friend, you get it from the environment. And these studies in CF patients used the question earlier referred to that. How do you know if it's the same organism or a new one? They look at the genetic fingerprint of the organism, similar to what Dr. Guierrini was talking about, looking at the features of the infection and to see if it's the same infection. And there's a fingerprint or a genetic genotype that goes with different strains.
Okay. How much variability in the heat map do you see with repeated samples from a healthy subject?
I think this is a really great question. So we didn't do analysis on repeated samples, so I cannot comment on that. But I know from previous studies that it's possible to have some variabilities between the repeated samples. It's what it is. And unfortunately, you cannot ask the patients to do induction like 2-3 times in a day or over 3 days. So that's unfortunately a limitation of the study. But this is what it is, because you cannot really subject the patients to multiple rounds of induction.
One of the challenges we had was people would get a positive culture, come to be in the study, and then they couldn't make sputum. And it's hard to rationalize putting someone under sedation and doing bronchoscopy if they're not sick. So healthy people don't produce enough sputum for us to analyze, and subjecting them to a risk just for our curiosity was a little harder to get past the institutional review board. So
if significant biomarkers are identified, roughly how many US labs would be sophisticated enough to do this type of analysis?
Oh, yeah. So I want to focus really on something that then can be measured by using immunoassays. So that's why, and the immunoassays are assays that are used at any LabCorp location or Quest, so that any clinical lab could do. So has to be a marker that is in good abundance, first of all. and then has to be a marker that is quantifiable by using immunoassays. Even if immunoassays are not currently available, you can still contact companies and ask them to do customized immunoassays, and then they can become clinical practice. So yes, definitely that's an important aspect of it.
So you're focusing on biomarkers that can be measured in commercial labs?
Oh, yes.
Okay, great. Somebody's asking why a urine sample versus a bowel sample?
Yeah, I think first of all, logistic reasons. I think it's easier just go, to the visit and produce a urine sample, and yes, and second of all, is because our blood is filtered through our kidneys, so whatever is in the blood then ends up in the urine, so it's a good sample.
That makes sense.
Yeah, to measure markers.
Okay. What antibiotic treatments specifically were the patients using?
So that was something that was very important to the consent process, is that we followed the standard of care guideline-based treatment. So for example, treatment of Mycobacterium avium complex, MAC, would include rifampin, azithromycin, and ethambutol, depending on the sensitivities. But we had a few patients that couldn't tolerate rifampin. We had patients that stopped azithromycin because there was concern about hearing loss. The patient that stopped all three, he went into the hospital with severe chest pain, and nothing was ever diagnosed. His heart was fine. There was no esophageal problem. There was no new lung findings. And he ended up going back on the normal therapy without any chest pain. I would have to, the patient who had Mycobacterium canzaceae, I followed the rifampin, isoniazid, ethambutol protocol. So I can't answer for all the patients, but we used guideline-based therapy. We had patients on clofazimine who needed that.
Okay. Next question, let's take a look. How often should a patient have a sputum test, or should a patient have a sputum test between each doctor's visit?
I love getting sputum. It gives me more information to work with. The logistics are not quite so friendly for that. So often the morning sample, which is the best, is the only time they produce sputum, and we were limited by that because we were processing right away. Monthly is my preference, to minimize the treatment burden. Sometimes patients were coming from 3 hours away, and I know at bigger centers like National Jewish Respiratory, they will actually send an apparatus, and the patient will put their sputum in the mail and send it to them for monitoring. So my guideline is once a month at the minimum, and once every 3 months at the minimum, because I see patients every 3 months at a minimum. But I try to get it, especially in the acute phases of figuring out what's going on, every month. And again, it's going to vary depending on logistics, patient factors, and ability to produce sputum and get it to the lab.
Okay. Somebody's asking, what would prophylactic NTM treatment look like?
So in cystic fibrosis with patients who are colonized with Pseudomonas, they'll inhale an antibiotic month on, month off. I've had patients on a prophylactic regimen of 3 times a week of inhaled tobramycin. That would be for Pseudomonas. Now with NTM disease, and this is just clinical practice, I've had patients who've had MAC, severe bronchiectasis, cleared it, continued it for a year, and then it only comes back as soon as they stop the antibiotic. And so we've come up with a regimen that's well tolerated and seems to prevent it from coming back. So it might be 3 times a week. I have one patient who's rather severe, who's on essentially prophylactic antibiotics for life, because every time we stop them, it comes back. So that's a more advanced decision that you would get expert advice and make that decision in collaboration with your doctor. I wouldn't prescribe a regimen for all people.
Okay. If a patient cannot produce adequate sputum, should the doctor do a procedure from the lower lung? I guess maybe
I,
where
gue-
would
I
they
mean,
fit?
I guess this is based on the clinical indication, right? So not for the study, of course. If the patients needs it for diagnostic reasons and they undergoes the bronchoscopy, then we can get part of that sample, but just because the patient is doing it for clinical indication.
Right. If a person is symptomatic but can't produce sputum, then we'll do a bronchoscopy. That was not the norm in our patient. We had one patient who continued to present with symptoms and couldn't produce sputum, so we did the bronchoscopy on her, and that was allowed us to guide her therapy.
Okay. Has there been any significant preclinical research done using the sputum, urine, blood of a multitude of patients that includes water and soil or dust samples to identify certain proteins among certain contaminants?
So I know that there are no studies done collecting so many different types of specimens. I know there are studies done and actually, I think these studies are also funded by the NTM IR to try and correlate the isolates found in water systems and in people. But really collecting all these types of specimen and also samples from the environment at the same time, I think there are no studies for that.
Do you have a take on potential lung probiotics as a complementary or adjunct therapy?
That's an interesting question. You know, sometimes we'll give bacteria to the digestive tract for patients who've had their flora replaced by Clostridium difficile. And those probiotics and prebiotics are good for the digestive tract. There is no form of introducing a healthy flora to the airways that I'm aware of.
Okay.
But it could be good to do if we had these tools in clinical practice, because, you know, for example, is from this study we find that if a patient is responding to the treatment, he has a specific like microbial flora, then this means that that specific flora is associated with treatment response. So then it means that probably those bacteria are good for your health. And then if we had a way of putting those bacteria inside people, inside the lung, then it would be, you know, like the new drug. So
Okay.
as I was saying before, this study is not only, you know, it's not only for discovering biomarkers of treatment response, but can also help generate hypotheses on pathogenesis, so you can find new targets for therapeutic intervention.
Okay. We now have a series of questions that are dealing with NTM and TB. And I saved that towards the end because it's a series of questions along the same vein. What should be the approach to doing proteomic analysis to differentiate between TB and NTM? And is there a study that's been done to compare these cohorts?
So I'm aware of one study that has been done to compare TB and NTMs by doing, if I remember well, was blood proteomics. And some differences were found. But again, that looks at host molecules, so host proteins. Yeah, this is the only study I'm aware of comparing the two.
All right.
Yes.
Next question. Could we go for plasma proteomics for NTM patients?
Yeah, definitely you could do that. Yes, you could do that. It's just that we focused on the lung because this is where the infection occurs.
Right.
So, you know, we thought it is more likely to find something that really changes with the treatment. And that was our rationale, but certainly you can do plasma proteomics, yes.
And
Yeah, go ahead.
I was just going to point out here, when we get your interferon gamma release assay test for tuberculosis, all we know is that the patient has been exposed to TB, but it comes back to the clinical decision. Is there damage ongoing to the lung? Is the organism present in the sputum? So sometimes those markers, maybe like footprints in the sand, you don't know if the bad guy is still in the neighborhood or he's gone a long time ago and you cleared it already. So it's a bit it's once removed from the site of action.
Got it. Oh, that makes sense. This same person is asking if you can comment about biomarkers for NTM patients who are misdiagnosed as TB patients and receive anti-TB treatment. I guess, would it change the biomarker profile?
So those are, so what's the question again? These are patients that were misdiagnosed.
So they're requesting comment about biomarkers on NTM patients who are misdiagnosed with tuberculosis and receive anti-TB treatment.
So I know there's a few causes of false positive tests for T-spot or interferon gamma release. I think mycobacterium marinum or, for example, will create a false positive. Fortunately, there's some overlap with the antimycobacterial drugs. So, treatment is based on the best information you have and then culture and serial culture to follow up. I think a biomarker that's precise to identify the species of infection would be something we would be looking for.
I think if you're looking at the biomarker of treatment response, it really comes down to the fact if the treatment is working. So if you're using, a treatment for TB that is not the same as a treatment for NTM because you are misdiagnosed, I don't know, probably the treatment is not going to work.
Right.
So then if the treatment is not going to work, then you can expect similar changes in the lung environment. And then probably you can use the similar biomarkers because it's just the treatment didn't work.
Right. If the biomarker is
so it's still a biomarker
treatment,
of non-responder.
Right. If the biomarker is for treatment, then it presupposes you knowing what species you're treating. Otherwise,
and if the treatment doesn't work,
then you're not
you just have a marker of non-responder, basically.
Okay.
Yeah.
The same person is asking you to comment for countries that have a high burden of tuberculosis. What should they be thinking about in terms of an approach to do a TB versus NTM study, biomarker study? A TB versus NTM biomarker study.
If you want to distinguish between the two, you will have to do a molecular test. So you will have to really take the sputum sample, and then I think there are some molecular tests that are specific for the species. For TB or NTM, some of the NTM species are available, and then you will have to do what is called the PCR. It's a molecular test that really distinguishes the two species. In terms of a biomarker, yeah, you cannot do that. I mean, you can do again an interferon gamma release assay that is going to tell you if you have been exposed to TB. You don't know if you have been exposed 10 years ago or if you're currently infected, unfortunately, with that test. So the only way is to take the sputum and do a molecular test and see what pathogen you have.
Right. Do you have any reports about differences in proteomic profiles of respiratory samples obtained from Kansasii versus TB patients?
No, there are no reports.
Okay. All right, well, that was the question. Thank you so much. We've actually answered all of the questions that were
okay,
in the
great.
queue. That was a long one, so thank you for bearing with us. I'd like to thank everybody for bearing with us, and thank you all for joining us today. Dr. Klingsberg, Dr. Guierrini, thank you so much for a wonderful presentation. We really appreciate the time you took today. It was a wonderful webinar. Thank you, everybody, for joining us, and we look forward to seeing everybody again soon.
Thank you for having us.
Thank you. Bye-bye.
Bye-bye.
Bye now.